Thank you so much, Dr. Ahmed, for this introduction, and thank you everyone for giving me this opportunity. It's my honor to be presenting in this webinar, and it is a special honor for me to be presenting in the same session as Dr. Masian. So today I will try to shed some lights on the placental mediated diseases, and as you said, which usually are acronymed as PMD. So I will start with my question, why is this important? Why now? Why it's really important to learn more about the placenta and about the placental mediated diseases. So first of all, the placenta is the root cause of many diseases. And this pathology usually starts in the first trimester, as Dr. Masiano has kindly explained to us. And unfortunately, there is a poor attention to the first trimester, and especially a poor attention to the placental morphometry during the first trimester. Fortunately, there is preventive modalities that are available to prevent these early pregnancy complications. That's why it is time to give the placenta attention and respect. And based on these points, the NIH is currently funding a very big project, about $80 million project called the Human Placenta Project. And this, what they say on their website, they said that the placenta is arguably one of the most important organs in the body. It affects not only the health of a woman and her fetus during pregnancy, but also the lifelong health of both mother and child. They said that despite its importance, we know little about this critical but temporary organ. And this project, which started in 2014, aims to develop new tools to study the organ in a real-time fashion, to learn how it develops and functions throughout pregnancy. And I will take this opportunity to invite you to attend the 6th annual Human Placenta Project meeting, which will be held virtually on May 10th and 11th. This meeting is free, but registration is required. And I am very excited to attend this meeting. Okay, so based on the above two slides, the flow of our talk today will go as follows. I will talk a little bit about the background, but thankfully Dr. Masiano had paved the road for me, so it won't be as difficult. Then I would talk about the definition of these placental mediated diseases. What are they? How do they occur? How can you screen for them? And what are the preventive modalities? Can you treat them? And then I will talk about a concept which was introduced recently called the placenta clinic. So as Dr. Masiano has explained to us, the blastocyst consists of the inner cell mass and the outer trophoblast, and this trophoblast develops into the placenta. Here, the blastocyst adheres to the decidual epithelium, and it sends villi to burrow itself into the maternal uterine wall. And as you can see here, this is the decidua, and this is the myometrium. This is the spiral artery, which is the final branch of the uterine artery. When we take a closer look, you can see here that this is a villi, and there are two types of villi. As Dr. Masiano has said, there is the floating villi, and there is the anchoring villi, which anchors the fetus to the uterine wall. And my focus today will be mainly the anchoring villi. Dr. Masiano kindly spoke to us about the floating villi and the role that the synthetic trophoblast played in pregnancy. And it's like the factory of pregnancy. Now I will talk about the other pathway, which is the extravillous trophoblast pathway. So here we have a villi. You have an outer layer of the synthetic trophoblast, and then you have the inner layer of the villous trophoblast. The villous trophoblast proliferate, and they form columns. And once they come adherent to the decidual epithelium, some of these trophoblasts leave the column and invade into the decidual epithelium. And there are two types of cells now, at least. One type is the interstitial extravillous trophoblast, which invades and resides into the decidua. And the other type is the endovascular extravillous trophoblast, which invades into the spiral artery. These endovascular trophoblast in the beginning, they form a plug that plugs the blood to the fetus during the first 8 to 10 weeks. And during this period, it is very important to have a physiological hypoxic environment, which is important for both placental development, proliferation, differentiation, as well as this is the period of organogenesis. At the end of 10 weeks, this trophoblast plug starts to dissolve, and the trophoblasts start to migrate into the spiral artery deeply. And this migration is stimulated and aided by the decidual maternal cells. As Dr. Massiano have mentioned, we have the decidual maternal cells, especially the natural killer cells and the macrophages. These endovascular trophoblasts invade, and along with the decidual cells, they transform the spiral artery. They model the spiral artery. And when we say spiral artery remodeling or transformation, we mainly focus on the effect on this interaction on the smooth muscle layer of the spiral artery. And I will talk about this in details later. So here, this interaction that I mentioned about the decidual maternal cells and the EVT will affect the extravillous trophoblast invasion, as we said. And these 3 points, which are the extravillous trophoblast number, extravillous trophoblast interaction with maternal decidual cells, and extravillous trophoblast invasion, will play a very important role in what we call the spiral artery remodeling, which is very important for our talk today. So let's shed more light on spiral artery remodeling. Here is the spiral artery, and this is the decidual part. This is the myometrium part. Normally, the transformation or remodeling happens in all the decidual part and in the medial third of the myometrium. So you can appreciate here that the spiral artery is dilated. What happens is the smooth muscle cells of the spiral artery become replaced by fibrinoid material. Thus, the spiral artery become unresponsive to the vasomotor control of the mother, yielding a big blood conduit, which is important for large blood flow to the developing fetus, as you can see here. This is the brown actin smooth muscle cells, and you can appreciate here that this is just a thin layer, and you can appreciate the wide diameter of the spiral artery when we take a cut section in this area. Let's see what happens in the normal cases. How about abnormal situations? In abnormal situations, the spiral artery remodeling is partial or incomplete, meaning that it can happen up to the decidual part of the spiral artery, but it doesn't involve the deep part, the deep placentation part. So if we took a cut section in this deep part, you can see the spiral artery as follows. Here you have many layers of smooth muscle cells, as well as the diameter is narrow. Okay, so what causes the abnormal spiral artery remodeling? So first, there are many hypotheses, and we will talk about this hypothesis, which says that it all starts with inadequate histotrophic nutrition in the beginning of pregnancy, which leads to insufficient number of extravillous trophoblasts, as well as there is abnormal interactions between the maternal immune cells and extravillous trophoblast, which we mentioned before that this is very important for extravillous trophoblast invasion. Thus, you will have limited extravillous trophoblast invasion. These two, along with abnormal maternal vasculature, will lead to deficient in spiral artery remodeling. What are the consequences of this abnormal remodeling? Well, we said that the main thing is the persistence of the smooth muscles. So you will have maintained visual reactivity. The spiral arteries will be responsive to the vasomotor control. So they will contract and dilate, maintain visual reactivity, as well as you have narrow spiral arteries, so the blood velocity will be high. The maintained vessel reactivity will result in ischemia, reperfusion injury. The high blood velocity will result in mechanical damage of the placenta. Both of these will end in placental malperfusion and oxidative stress, which will lead to placental insufficiency. To this end, we can come to what are the placental-mediated diseases? The placental-mediated diseases, or PMDs, they are a group of pregnancy complications that result from placental malperfusion or insufficiency, mainly due to abnormal spiral artery remodeling. They are about 5 to 7% of pregnancies will suffer from placental-mediated diseases, and these include early preeclamptic toxemia, early fetal growth restriction, preterm labor, second trimester abortion, and several adult onset diseases. Also, some people would argue that gestational diabetes can be included in this group. Some researchers name this group as the Great Obstetric Syndrome. Today, my main focus will be on the early preeclampsia. And in my next presentation, which will be in 2 months, we will talk about the several adult onset diseases that have a placental root. So how do they happen? So we said it starts with placental insufficiency, which will result in abnormal nutrient and oxygen transport to the fetus and the placenta. And the underlying cause of all of this is the abnormal uterine spiral artery remodeling, mainly. As we said, that the abnormal spiral artery remodeling will lead to maintained vessel reactivity, high blood velocity. This will result in ischemia, reperfusion injury, mechanical damage of the placenta, and will end in placental malperfusion and oxidative stress, as we said. Placental malperfusion will lead to fetal growth restriction because the placenta is small. There is not enough nutrients and oxygen going to the fetus. So this will end that the fetus will be small. And their effect on the placenta is as follows. The placenta doesn't have enough oxygen, thus you will find placental infarctions, and the stressed placenta starts secreting harmful chemicals, mainly pro-inflammatory cytokines and anti-angiogenic factors. And this will go into the maternal circulation, affecting the maternal endothelium. Thus, this is the basis of the two-stage placental model for preeclamptic toxemia. They said that the preeclamptic toxemia, mainly the early preeclamptic toxemia, which some people also name as placental preeclamptic toxemia. They say that the stage starts early on in the first trimester. It starts with the placenta. The placenta is hypoxic and it's under stress. Thus, it will start secreting harmful chemicals like pro-inflammatory cytokines and anti-angiogenic factors. These factors will go into the maternal blood vessels and they will negatively affect the maternal vasculature and endothelium, which can end in end organ injury, like what happens in the cases of severe preeclamptic toxemia. Is there any way to screen for these diseases? Fortunately, yes. So the thing is that we can start screening and looking for these diseases early on during the first trimester, from 11 to 14 weeks. We can screen by using different models. First, we can use the maternal history alone, mean arterial blood pressure. We can use ultrasound and MRI to look for the placental morphometry and biometry. We can also use Doppler. And finally, we will talk about the serum biomarkers. These are the screening modalities. And as I said, I want you to go with me and focus on the first trimester only. So you have your pregnant woman. She just know that she was pregnant. You saw her in the first trimester, for example, at 8 weeks. So you will start to take history. The American College of Obstetrics and Gynecology and the Society of Maternal-Fetal Medicine, they have a list of 6 points that if any pregnant woman has any one of these, she will be considered high risk. These are history of preeclamptic toxemia, multifetal or multiple pregnancy, chronic hypertension, renal disease, autoimmune disease, such as systemic lupus or antiphospholipid syndrome, type 1 or type 2 diabetes. Any pregnant woman in the first trimester, when you see her, that you find that she has any of the following, this means that she will automatically be in the high risk group. And I will talk later, what does this mean and how can we use this? The moderate risk, if your pregnant woman has 2 or more of the following, she will be categorized in the moderate risk. These are 9 points. Also, they are by the ACOG and the the Society of the Maternal-Fetal Medicine. These are nullipara, age more than 35 years or older. The last pregnancy is more than 10 years. The BMI is more than 30. There is a family history of preeclamptic toxemia, either in the mother or the sister. This is a close family history. African ancestry, low socioeconomic status, or the patient herself was born low birth weight, or she has a history of low birth weight or other adverse outcomes. 2 or more will categorize your pregnant woman in the moderate risk group. The second screening modality is by looking into the placenta, and actually the placental morphometry, the antenatal placental morphometry, is usually focusing on just looking on the location of the placenta and the invasiveness of the placenta. But recently, because of the Human Placenta Project, there is more focusing on the screening of the placenta in the first trimester. They are trying to give us like reference values, the normal reference values for the placenta during this trimester. So in ultrasound, you will look for location as usual. You will look for any abnormal shape. You will look for the cord insertion, the volume, any infarcts, and also the MRI, but the MRI usage is limited due to the limited availability and high cost. So how to measure for the placental width and diameter. So here you find, this is an ultrasound and this is the placenta in 13 weeks pregnancy. They measure the placental width at the level of the umbilical cord. Here, as you see this yellow arrow, and the placental length is measured from this star to this star. And by getting the placental width and the placental diameter, you can calculate placental volume. And it was found that in placental mediated diseases, the placental volume, you expected it to be less than normal. And as I said, there will be reference values coming out soon regarding the normal placental morphometry and biometry. The other imaging technique, which was and still very valuable, is the Doppler. But put in mind again that we are now talking about first trimester Doppler, not second or late. You can do Doppler on either the maternal side, on the uterine arteries or spiral artery Doppler, or the fetal side, umbilical artery, middle cerebral artery, or ductus venosus. And also as a fruit of the Human Placental Project, they were able to change or upgrade, if you will, the Doppler techniques. So the basic principle of the Doppler is to measure the blood flow, and the conventional Doppler imaging couldn't see the low flow in the small vessels. It's usually lost. Thus, you can only see the flow in the relatively big vessels. But recently, they developed an algorithm that can remove the clutter and preserve the low flow. So now they are able to perform Doppler on spiral arteries. So these small branches, you can see, you can evaluate them using Doppler. And this is a video showing how this is Doppler of the spiral arteries. See how they can see the blood flow in the very small branches. The third or the fourth marker that I will talk about today is the biomarkers. These are a group of serum and urine markers that were measured to predict preeclamptic toxemia. And as Dr. Masiano said, the placenta is a factory that produces like hundreds of hormones and proteins. Many of these hormones and proteins were tested to see if they are suitable for prediction of early preeclamptic toxemia. But I will just focus on the most common today. So there are angiogenic, anti-angiogenic markers and placental proteins. We have the soluble FLT1. We have the placental growth factor, vascular endothelial growth factor, and the soluble endoglins. For the placental proteins, we have the pregnancy-associated plasma protein A, HCG, placental protein 13, alpha-fetoprotein. The commonest that are being used and implemented clinically are the soluble FLT1 and the placental growth factor, as well as the pregnancy-associated plasma protein A. So talking about these four prediction modalities, people, when they did research to see what's the predictive value of each one of these, they found that individually, each one can predict, but the predictive value or the detection rate is low. But they found that when they combine them, you will get a higher detection rate. And let me explain how. So first, we will talk about the maternal factors. If you will only take a history from your patient, a very clear history, and you categorize her into the high risk or the moderate risk, you can prevent 53% of the early preeclamptic toxemia before 32 weeks, 45% of the preterm preeclampsia, and 34% of the term preeclampsia. If you added the mean arterial pressure, your numbers will jump up a little, so you can detect 61%, 51% of the early preeclampsia and preterm preeclampsia, and not much of the term preeclampsia. However, if you used, instead of the pressure, of the mean arterial pressure, you use the Doppler uterine artery pulsatility index, the number will jump to 70% and 58%. If you used all of these, the maternal factors, the mean arterial pressure, the uterine artery pulsatility index, your detection rates will jump to 83%. You can detect 83% of early preeclamptic toxemia and 68% of the preterm preeclamptic toxemia. If you added the serum biomarkers, like PLGF or PAP-A, your detection rate will jump into 90%. So here, from 53% to 90%, you will detect 75% of preterm preeclampsia. However, your term preeclamptic detection rate is not that much different. And I want to talk about this model because this combination model is recommended by the foundation of the Fetal Medicine Foundation, and they named it the FMF triple test. So you have maternal factors plus 3 other tests. Why they did this? Because ACOG and NICE guidelines, till now, they are mainly dependent on the maternal factors. They don't recommend any of the other screening factors. But the foundation of the fetal medicine, they recommend adding to the maternal factors the mean arterial pressure, the uterine artery pulsatility index, as well as placental growth factor or placental associated plasma protein A, either one of these. And you can appreciate the huge difference in the detection rate between using only the maternal factors, as said by the ACOG and NICE guidelines, and the implementation of the FMF triple test. How about if you are in a low resource setting, you are not in a tertiary setting, or you don't have, can do Doppler or can do the serum biomarkers? Okay, so we said that if you only depended on the maternal factors, you can detect 53% of the early preeclamptic toxemia. And if you add the mean arterial pressure, which you can do anywhere, you will jump to 61 and 51%. So we will say that the minimum thing to do in the first trimester to predict preeclamptic toxemia is to look for the maternal factors, the 6 high-risk maternal factors and the 9 moderate-risk maternal factors, as well as to measure the blood pressure and take the mean arterial pressure. And the FIGO now encourages all countries to ensure that resource-appropriate testing for preterm preeclampsia become an integral part of the routine first trimester evaluation protocol offered at all maternal health services. And this is the minimum that you can do. Thus, maybe now it's time to invert the antenatal care pyramid, because this is the conventional antenatal care pyramid, which has been in place for 80 years and it is implemented till now. And as you can appreciate, we only see our patients maybe once at 12 weeks and once at 6 weeks. And as you go up in gestational age, you increase your visits. But maybe it's time to invert this pyramid. And this is the proposed new pyramid for the prenatal care. They propose that you should increase the visits in the first trimester. And based on this, you will classify your patients into high risk or low risk. The high risk should be seen by a specialist from 12 weeks to 34 weeks. And then the low risk would be seen at 20 weeks. Both of them will be reevaluated again at 37 weeks and again at 41 weeks. So when we say screening will only be important if it gives you meaning, if you can prevent what you are screening for, because if you can't prevent what you are screening for, then it's a waste. So can you prevent PMDs, or specifically we will talk about early preeclamptic toxemia? There are different modalities that have been proposed, including low-dose aspirin, low molecular weight heparin, calcium, antioxidants, omega-3, statins, and calcium channel blockers. However, the only evidence-based prophylactic modality that is approved and recommended is the low-dose aspirin. And this was especially after a very big study called the ASPRI project, which is a multi-center study. They performed this study in 6 different countries. They were screening all pregnant women at 11 to 13 weeks. They had about 30,000 women. And the number of high-risk group that agreed to be randomized are about 1,600. These 1,600 were assigned to aspirin, randomly assigned to aspirin and placebo. And they were given aspirin 150 milligram per day at nighttime from 11 to 14 weeks till 36 weeks. And take care that the first trimester is a key in both screening and a key in both in the treatment. What did they find? They found that using aspirin can cause an 82% drop in the rate of early preeclampsia and 62% drop in the rate of the preterm preeclampsia. not much affecting the term preeclampsia though. But here we are focusing on the early and preterm, and you can appreciate the wonderful results that they had. Thus, the guidelines, both the American College of Obstetrics and Gynecology and the Society of Maternal-Fetal Medicine Committee opinion, they have the following guidelines for low-dose aspirin. Who should take it? All patients, pregnant patients with any single high-risk factor, and we should take low-dose aspirin, and any pregnant woman with more than one moderate risk factor should be considered for low-dose aspirin. When? They said that at 12 to 28 weeks, but optimally less than 16 weeks. And I want to go back to the slide of the aspirin and see here the maximum effect was from 11 to 14 weeks. This effect was at 11 to 14 weeks. This means that before 16 weeks. So it's optimally less than 16 weeks, and they continued daily until delivery. This is the new recommendations. The dose, they recommended 81 milligram because this is the dose present in the US, but some practices, they said that some practices may consider a higher dose. We can use from 81 to 150 milligrams. And since the maternal factors are very important, and since they are sort of all over the place, some like in the present history, some in the past history, family history, medical history. So the Society for Maternal Fetal Medicine prepared a checklist for all healthcare providers that they can use in their practice. And this checklist have the 6 high-risk factors and the 9 moderate risk factors. And they say, if your patient had any of these, recommend prophylactic low-dose aspirin if any of these factors are present. And for the moderate, consider prophylactic low-dose aspirin if more than one. And these, I will not go again through them, but these are exactly the ones that we mentioned before in the maternal history. And also the guidelines say that in the absence of the risk for preeclamptic toxemia, the low-dose aspirin is not recommended for the sole prevention of the following: fetal growth restriction, preterm labor, and stillbirth. Although some studies found a favorable effect of prophylactic aspirin in preventing these disorders, however, the numbers are not high enough to recommend. Also, it is not recommended to give it only to prevent early pregnancy loss. For the fetal growth restriction, preterm labor, stillbirth, as I said, despite some favorable effects, but the evidence is insufficient to recommend it to be implemented clinically. And for the early pregnancy loss, it was shown to have no benefits at all. How does low-dose aspirin work in these cases? So we all know that the aspirin is COX-1 and COX-2 inhibitor. And they found that this is a dose dependent, meaning at a low dose from 60 to 150 milligram, it mainly inhibits COX-1. Thus, it mainly decreases thromboxane A2 without an effect on prostacyclin. And we know that thromboxane A2 has a vasoconstrictor effect, and the prostacyclin has a vasodilator effect. Also, it was proposed that aspirin can increase the placental growth factor secretion. And as Dr. Masiano said, this factor is important in the angiogenesis. It increases the angiogenesis and making new vessels. And it can inhibit the production of the soluble FLT1, which is the soluble receptor for vascular endothelial growth factor, which compete with the circulating vascular endothelial growth factor, thus leading to a low level of the vascular endothelial growth factor, which is important for angiogenesis. Aspirin was found to inhibit its production. What are the contraindications? Well, we have absolute and relative. Our absolute contraindications for aspirin: non-steroidal anti-inflammatory drug hypersensitivity, presence of a nasal polyp because it can cause bronchospasm, history of asthma, and history of aspirin-induced bronchospasm. These are the absolute contraindications. There are also some relative contraindications if you have a history of bleeding, either GIT bleeding, genitourinary bleeding, or you have active peptic ulcer or severe hepatic disease. These are considered relative contraindications. And I find this 2020 review article that really did a very good job in putting a scheme, a proposed screening and management scheme during pregnancy, starting from the first trimester till delivery. So what should you do? So in the first trimester, they said all pregnant women, you should take the maternal factors, the history from them, maternal history, measure the blood pressure, do uterine artery parasiticity index, and do placental growth factor. And based on this, you will assess the risk evaluation for preterm preeclamptic toxemia. Based on your results, you will have either high risk group or low risk group. The high risk group, you will start immediately by giving them aspirin, low dose aspirin, in case, of course, that there is no contraindication for the treatment. Low dose, don't give aspirin. And you will closely follow until the second trimester. In the second trimester, you will add another test, which is the soluble FLT1. And you will do another risk evaluation. If it is still high risk group, it will still undergo high-level surveillance for preeclamptic symptoms and signs between the 24 and 35 weeks, and you reassess at 36 to 37 weeks. If it is low risk, then we will do the standard surveillance. In the third trimester, you will do a triple test, which includes the measuring the blood pressure, doing placental growth factor, and measuring the soluble FLT1. And you assess the preeclampsia again, the symptoms and signs and the risk for preeclamptic, and you will manage accordingly. High-level surveillance or induction of labor, and the low risk will be the standard surveillance. And the Fetal Medicine Foundation have a calculator, which is a preeclamptic toxemia prediction calculator on its website. This calculator is an interactive one, can be used by any physician. So it is in the 11 to 14 week time, as we said, and this calculator, you just enter the data and it will calculate the risk at the end. So you will say if it is singleton or twin, the crown rump length, here you have some maternal characteristics and the maternal history, obstetric history. Here you will put the blood pressure, the pulsatility index, and you will put the biochemical measurements, either placental growth factor, or you don't need to do both. You can do either placental growth factor or PAP-A, and then you will just click calculate risk, and it will give you the risk of preeclamptic toxemia, and you can manage accordingly. How about treatment? We talked about screening, we talked about prevention. If it happened, can we treat it? The early preeclamptic toxemia or early pregnancy-mediated diseases, mainly early preeclamptic toxemia or early fetal growth restriction? Well, there are different treatment modalities that have been suggested, and many research that have been done, starting from heparin to sildenafil up to antioxidants and apheresis. However, there is not enough evidence to implement it clinically and to recommend it for everyone. Now we are toward the end of the talk, and I want to introduce a very interesting concept called the placenta clinic concept, which actually is not a new concept. It has been around there for about in the last 20 years. And this is like a special clinic which have different multidisciplinary specialists that are focused on surveilling or on picking up the pregnant women who are at high risk early in pregnancy. And I have here the one example of one of these clinics in Ottawa Hospital. It's called the Placenta Health Clinic.
And the Ottawa Hospital Health Clinic, they have a multidisciplinary team where they have maternal-fetal specialists, perinatal pathologists, ultrasound specialist, OBGYN ultrasound specialist. They even have a psychologist, neonatologist, anesthesiologist, labor and delivery staff, nursing team trainees. All of these people are part of the multidisciplinary team of the health clinic. What does this health clinic do? Well, it can even start before pregnancy, before conception. It provides pre-pregnancy consultation based on the risk factors, and it can design and implement a plan of care. It promotes evidence-based research related to placental disease, and it educates patients, families, and physicians on placental-mediated diseases and ways to prevent them and to screen for them. And I have a screenshot here of their web page. This is the Ottawa Hospital. This is the Placenta Health Clinic. And you can see that their mission is to provide excellence in prevention and treatment of placental-mediated diseases. And they educate about what are the placental-mediated diseases and the objectives and what they do in this clinic. So the take-home message that I want you to leave with is, or are, what are placental-mediated diseases? These are a group of diseases resulting from defective placentation. They include early preeclamptic toxemia, early fetal growth restriction, preterm labor, second trimester abortion, and some adult onset diseases. How do they do? How do they happen? They happen because of mostly the underlying mechanism is failure of spiral artery remodeling. How to screen? You screen between 11 weeks and 13 and 6 days weeks. You screen by taking history, measuring the blood pressure, doing uterine artery Doppler, measuring serum biomarkers, either placental growth factor or PAP-A. You can prevent using low-dose aspirin before 16 weeks till delivery. And the treatment, there is not enough evidence to recommend any treatment modality for PMDs. And by this, I come to the end of my talk, and I hope I shed some light on the placental-mediated disorders. And thank you, and ready for any questions that you have.
Well, thank you very much, Professor Faten, for such a wonderful presentation. And as we have seen over the past few decades now, as students, you remember, Professor Faten, we were taught that preeclampsia and many other obstetrical problems were so much enigmatic, etiology of which is not very well known, prediction, prevention, and consequently treatment, of course, are far from being complete. And here, decades after, we're not that old anyway, but only men get older. Anyway, now that we have tends to have a clearer image of what happens. We used to think of the placenta as that part of the afterbirth. So it's now evolving after your talk and that of Dr. Misiano, is that the placenta is an organ, a very unique organ, a temporary function, well, a second brain possibly as described, or a relay station for a neuroendocrinal control in pregnancy. So it is not only a peculiar organ, but also the source of specific disorders. Now we know that the placenta is the cause of disease, as you've said, and we now hear of the acronyms like placenta-mediated diseases, like placenta accreta spectrum. So we do have we're doing fine. It's another milestone in the evolution of obstetrical services. So thank you very much for highlighting this. And of course, it's of great importance to pinpoint how prediction, which tests work. And I think that the time has come when we talk about the triple test in fetal diagnosis. Now we have a triple test for prediction of and possibly prevention of such a catastrophic disease. So thank you very much for taking this into concept. We do have a number of questions, Dr. Faten, for you. And first of which I would like to ask you, when to stop low-dose aspirin before delivery, or possibly extend its usage in the postpartum period? Because as you know, people have been quite cautious, possibly erroneously thinking that it might lead to unnecessary bleeding. So I would like to comment on that.
Sure. Yes, when I was studying, we said that we shouldn't give aspirin late in pregnancy because, as you said, but recently there are many studies that have been done that showed that low-dose aspirin can be safely given till delivery. And based on this, the ACOG and the Society of Maternal Fetal Medicine recommend giving it till delivery.
Yeah, so this is a point of emphasis. I think this would be of great value to our practitioners, both young and old, to know that it is, as you've said, it's quite safe. This is an unfounded, maybe something like, unfounded fears about potential bleeding, only on those predisposed, of course. Now, the second question is, why is low-dose aspirin best given in the evening or at bedtime?
Yeah. This is interesting. The aspirin study, they gave it at night, and they said that they found, like in their pilot studies, that giving it at night is better than giving it during the day. I don't have an explanation, and I don't think that they gave us enough explanation, but this is like an observation that they found.
Yeah, this does not really seem a very relevant question, but I will tell you that, could you shed some light on the pathophysiology of postpartum eclampsia or persistence of preeclampsia into the postpartum period?
Yeah, actually, there is a very interesting opinion that is coming lately, saying that the placental origin, so they are like arguing against the placental origin of preeclampsia, although they are very small studies, but there's like another opinion saying that, okay, since the preeclampsia can happen in the postpartum period, there is no placenta, why does it happen? So that's why there is another group of researchers that propose that placenta is not only placental origin, it's mainly dependent on maternal general factors, and these general factors affect the placenta rather than the other way around. So this is another proposal and another theory that has been developing lately, but there is not enough evidence, if you will, and it's still now the main evidence or the main theory is like abnormal spiral artery transformation leads to the other way, to the preeclampsia rather than the other way around.
Okay, some people will think that preferably examining the placenta at the time of labor by a pathologist in women at risk would better decipher the true nature of the problem and make sure that that is really the cause. What do you think about that?
Yeah, actually, I had some slides about the postnatal placental morphometry, but that I removed so that I said that I was just focusing on screening. But as you said, it could be a screening screening modality to screen the fetuses who have fetal growth restriction, which wasn't diagnosed. They might have average weight and average all these things, but they have like a little bit affection of fetal growth restriction that went unnoticed. So it is very important to examine the placenta postnatally, really examine it, because when I was doing labor and delivery back then, I know that the placenta is like the least respectable, the least organ that we respect. We just take the baby. This is the most precious, and then the placenta, and then when we take it, we just throw it. We really don't examine it. At least I wasn't doing this. The only thing you might look for is like if it's like retained piece of the placenta, or to make sure that there is no retained piece, look at the structure. But like the actual observation of the shape, the thickness, the size, the umbilical cord insertion. All of these things are really very important that can give us clues.
Another important question, I think that, well, what if low-dose aspirin is contraindicated? Do these women have a chance being given an alternative?
This is an interesting question that unfortunately I don't have an answer to. I didn't come across what to do in case of contraindication.
Yeah, because, okay, we've heard a lot about fetal programming and the impact of maternal nutrition, drug abuse, and many other possibly stresses too, on how much they influence fetal growth in utero and postpartum throughout the years for decades. This is quite established. Is there any way that fetal programming is in one way or another be related to abnormal placentation in the sense of being a placental mediated disorder?
Yeah, exactly. So actually the adult onset diseases now are grouped under the placental mediated disease because they said that their main origin is placental. And my second talk, hopefully I will talk about these adult onset diseases and how they are related to the placenta. And that's why we really, really need to pay much attention to the placenta because it doesn't only affect the mother, it doesn't only affect the fetus, it affects the baby and it affects him in his adulthood, and it might even affect the second generation. So it's really very important to pay attention to the placenta.
What if low-dose aspirin is given prior to 11 weeks? Now, you've said that based on the currently available best evidence is that low-dose aspirin be best given before 16 weeks, somewhere between 11 and 16. So what happens if a woman takes it before or prior to 11 weeks?
Yeah, and actually in the ACOG recommendation guidelines, they said that if the woman came to you and she's already on low dose aspirin due to any other dose, that's fine, she can continue on it. And they said also that there are some studies showing that it is safe even before 11 weeks.
Yeah, some say, I'm not quite sure that I agree with this, but some advocate gentle, blunt, that is to say, curettage of the placental bed postpartum and in any way related to a decreased instance of postpartum eclampsia. This sounds strange to me. I don't know any information about that.
Yeah, and also
this is one of the questions by the panelists. Do you have any idea about that?
No, I didn't come across anything like this.
Okay, talking about placenta accreta spectrum disease. Now, a growing problem which we all face nowadays because of the abnormally and alarmingly high primary cesarean section rate. Could placenta accreta spectrum be considered in any way as an abnormal placentation, an iatrogenic, secondary to endometrial scarring, or both?
So, yeah, I know this might be confusing because some papers, when they talk about placental mediated complications or diseases, they mention abnormal placental invasion, others don't. But I guess, I think they mean by placental mediated diseases like the diseases which don't look related to the placenta, like you won't think that they have a placental root. But of course, the placental invasion, malinvasion spectrum is related to the placenta. And of course, it is a placenta mediated. But I think it goes without saying that it is mainly due to a maldevelopment of the placenta early on. Yeah.
Well, thank you very much. We're running out of time. We've hoped to have another couple of important questions, but the time is over now. Thank you very much, Dr. Faten, for such an informative presentation. And we surely be looking forward to your coming presentations, not just one, many. And thanks also go to Professor Masiano. I hope this was an interesting evening or scientific event for all attendees, and we surely are looking forward for the coming events. Thank you all for watching and stay safe.